Dear colleagues, please, in the next couple of minutes, let me present our progress in the last 12 months since entering this renowned program. Our research was conducted in the field of electrophysiology procedures. We wanted to assess how the outcomes of these procedures could be improved. A few words about me. I'm working in the Vámosi Heart Centre of the university. My supervisor is Claudia Vivian Nagy. And when I first entered this program and first had to prepare a presentation, my vision was working at Semmelweis University and assisting achieving its goal to enter the first 100 universities in the world. And I wanted to take part in achieving this vision in whatever means I can. The specific fields we have investigated were firstly the comparison of ultrasound guidance with the conventional technique during the vascular puncture, and we have conducted a meta-analysis in this field. We are planning an RCT, and the second field was assessing and predicting the mortality after 1 year after a ventricular tachycardia ablation. So let me speak firstly about our first project. As I said, we conducted a meta-analysis in this question, if ultrasound guidance can reduce the number of vascular complications during the venous puncture during electrophysiology procedures. The most of the complications is in relation to the venous puncture during these procedures, about 6%. And we knew from other fields such as anesthesiology that in those fields it was shown that ultrasound guidance has a huge beneficial effect. It could reduce the number of complications, and in this way the associated costs and the burden on the patients could as well be reduced. In our field, it is not yet standard practice. A lot of EP labs are using this, but also in Hungary, but a lot of others are not. Regarding the PICO framework of our study, we wanted to investigate adult patients who underwent EP procedures. We wanted to compare anatomical landmark-based procedure with the traditional, as the traditional way, with the ultrasound guidance as our intervention. The primary outcome was major vascular complications as defined in the consensus document in the relevant consensus document of the 4 continents arrhythmia associations, and we assessed a lot of other secondary outcomes as well. If we could show that this has a huge beneficial effect, then of course this could decrease the number of complications by the introduction of the daily routine of every center. I mean the introduction of this procedure in the daily routine everywhere. So we conducted last November a systematic search. We found over 13,000 articles. There were 12 eligible full text in the end after the selection. Regarding our most important result, major vascular complications, that means aneurysms, pseudoaneurysms, AV fistulas, and major bleedings, they were reduced by over 70%. So we can say that with the use of this procedure, every 3 out of 4 major vascular complications needing surgical treatment or interventional treatment or transfusion. So every 3 out of 4 can be prevented if this is introduced everywhere. We also investigated minor vascular complications, and we saw an over 60% rate of reduction. There was also a significant reduction with the rate of inadvertent artery punctures, with the number of total vascular complications altogether, and also when we investigated the number of complications only among atrial fibrillation procedures, that means pulmonary vein isolations. There we could also, in this subgroup, we could also show a huge significant effect. So the strength of our study was, first of all, that we provided clear evidence that ultrasound guidance has significant benefits, and we have used a more consistent definition than previous papers. Also the statistics was improved. Of course, we have limitations. There was only 1 RCT among our papers, so that's why we also plan to conduct an RCT ourselves. According to this should encourage to be daily practice everywhere, and as I said, an RCT is planned in our center. The manuscript is hoped to be submitted in September, as you can see the status on this chart. The second topic concerns the prediction of mortality after ventricular tachycardia ablation. As you might know, ventricular tachycardia is a deadly disease, the most common cause for sudden cardiac death. You can implant ICDs, implantable cardioverter defibrillators. They are preventing sudden cardiac death, but this has still a negative impact on the patient's quality of life, and arrhythmias themselves are not prevented. So catheter ablation is a very important therapeutic method in this field. So we wanted to establish a risk stratification system to know how the mortality outcomes can be predicted. There is a huge difference, a huge heterogeneity among these patients. So telling in advance who can benefit the most from this procedure or who has to be followed more thoroughly can help us to make better clinical decisions. We used our ablation patients registry at the Heart and Vascular Centre, have included around 300 patients, have investigated 70 of their pre- and intra-procedural parameters. We have used these as an input parameter. We used supervised machine learning algorithms and could find that the random forest method was the best to predict the outcomes. We have used the area under the curve of the Vámosi curve to have a numerical value for the assessment of the fitness of our prediction. Our one has outperformed previously used established risk prediction scores such as the IVT score or the pain ESD score. We also wanted to have an assessment of the parameters which are the most important ones regarding the prediction. We could see that the mitral E-wave deceleration time, the presence of a CRT device, age, the presence of an electrical storm previously, and the hemoglobin value were the most important for the prediction. With our prediction system, we can tell in advance who will need more thorough follow-up. For instance, 1 month, in every 1 month instead of 3 months, we can pay better attention to them and think of more advanced, more invasive treatment strategies earlier. We have, as our future plans are, we have established already a web-based platform which can be used by colleagues in other centers, and if we have gathered enough data, we will use this for external validation of our system. As you could see, the analysis is finished, and we will start writing the paper as soon as the first paper is submitted. Here you can see a summary of the status of the projects I mentioned, and I want to say thank you for your attention. If you have any questions, I'm keen to hearing and answering them.
Congrats, this is a nice presentation. Peter, if you identify a patient with a higher mortality rate with this new machine learning based method, what would you do with the patient? What to say to him, her, what to do as the next steps? We do an ablation or schedule long-term monitoring for the patient. What to do with that patient who is at high risk by the calculation?
Thank you for the excellent question. The indication itself has to be decided, of course, based on the guidelines and based on the evidence which is summarized by this huge job the guidelines writing teams are doing. So first, or before this could change the indications and the decision on indications, what we know for sure is that this will influence the post-procedural follow-up. So you will want to see such a patient every 1 month instead of every 3 months. There were a lot of patients in the registry who were not even seen by our colleagues. They have died before the first follow-up visit. So of course, if you know about this, you know about the higher risk, you want to schedule a follow-up visit earlier. That's the most important effect this will have on daily clinical decision making. And of course, when you have this follow-up meeting, you will pay more attention to that patient. You will have more time maybe with him or with them. You will make more examinations. This all can be influenced by knowing about this higher risk in advance.
Thank you.
May I have one important question to the second project regarding VT ablation? Did you look at different endpoints of the ablation, whether tachycardias were inducible, not inducible, or either tachycardias were inducible, or when did the operator decided to finish the ablation? Because it's sometimes really, really difficult to say, now I'm finished the ablation.
Yeah, data on this is also included in the database I mentioned to you. Actually, there is a huge heterogeneity regarding the data quality. So, first of all, among earlier ablations, when there was no uniform ablation final document introduced, there was some of the data points missing. And I think the reason why this analysis didn't find a correlation with the inducibility of VT after the procedure might be that there were not enough data points regarding this data type.
Do you have data on how many patients were tried to be induced after ablation? So what percentage were induced or not tested? Sometimes we do not test after 2 or 3 hours of ablation. We say, okay, it's enough.
Yeah, or when the procedure has to be terminated.
Has to be terminated because of other reason.
Due to hemodynamic instability, for instance. We do have the data on this. I don't recall the exact numbers right now.